what's nice about that, and you guys probably remember this from your test, is you can use long or shorts on the S system or the SI. The difference was because for the standard system, you had to use all shorts or all longs and tell the system I'm using all shorts and all longs. The nice thing is that now with our quick click cannula mount, the grooves of the cannula can actually, there's sensors that it can actually see or tell, the system knows what size the cannula is. And why that's important is because for obese patients, fat isn't always uniform, so there might be some parts where you'd want a short cannula and some parts where you'd want a long cannula, so it's nice. But the system needs to know where the instrument's coming out. But the remote center for the long and short is the exact same place, it's just the distal part that's longer. So anyways, I'm giving you a lot more information. Just talk about, you know, what the cannula is and the different sizes.
May I ask you, do you have cannula, an intuitive cannula with Lila? Where the air goes in? No, the pressure, the insufflation.
Report.
How do you call it?
Oh, these, there's some cannulas that have that little
Steam
extra-
stacks.
You have them over there. Do you need to mention that?
Some of them have them and some of them don't. I mean, you could mention it too, is for, you know, for
So
smoke
having the
evacuation.
100 or the 105.
Is it?
It doesn't matter. If you have it, mention it.
How do you
It's
call
not.
that? I would call it Google because that's
Yeah.
easier. You call it the same?
Yeah, I used to call it more like it's like a smoke evacuation port. So for it to help with the smoke evacuation.
Okay.
The other thing, just to, so you guys know, they have these little wings here, and that's, I mean, I've heard different reasons, but it also helps so that it doesn't fall off the table.
That's the main reason.
Yeah. So it talks about here, so we talk about the remote center and the remote center boundaries. You guys all feel comfortable talking about that, hopefully by now. And then the camera arm. So the camera arm.
What do they mean? What's in the boundaries?
Two thin lines.
What?
The two thinner lines, is that
Oh, yeah, okay.
Yeah, so as you're pushing it through, and you can kind of see, and that's why so you're trying to describe all this so that when they start doing it, they can look on the screen, and when they're doing it through direct visualization, they know what they're looking for. All right, so the camera arm. So you're going to want to talk about that. The camera arm is we're going to use a third-party trocar, right? So this one we have is Ethicon. We also there's U.S. Surgical. All that's important to know is that this is not from Intuitive. So they want to be able to use the right trocar that matches with the right mount that they have. It's typically based off of the contract the hospital has. So, but just make sure they're using the right one. Typically, the ASM, you know, part of the whole capital deal, they'll make sure they have the right stuff. So, anyways, it's a third party. Is this reusable or disposable?
Disposable.
Disposable. Good. All right. So we do have the 12mm trocar. There's also an 8.5 trocar that we have. That's an Intuitive one. I don't think we have one here. But anyway, so again, there's the obturator that goes with this when you're first making your port.
So we do have, sorry, but you said we do have an Intuitive 8mm?
8.5. Yeah, we have an 8.5.
For the
camera.
endoscope?
For the endoscope, yeah. Yeah, we have an 8.5. When we first came out with the 8.5, you had to use and I don't have one here, but you had to use our 8.5 scope cannula. And now I believe we have like some third-party 8.5 ones. I haven't seen any, but so just make sure they're using the right scope. You know, based on their scope, they're using the right trocar. And then assistant port. So the 5, 10, 12, depending on what's going on in the case, right? What they're going to do with it, or any different ports. So you're just going to give a description about the different cannulas and trocars. Then you talk about port placement. So essentially, you just want to make sure you're reinforcing. So we're going to say this is a pelvic docking. So we'll say it's a hysterectomy procedure, and you're going to dock, you know, over the patient's pelvis. You're not doing side docking. So you just want to go through basic port placement and imagine you're talking to a, you know, scrub tech or a surgeon, and at this point it should hopefully be a review if they did all of their clinical pathway homework. So I would ask, you know, my customer, so what, you know, so tell me what's the proper placement for the camera port. So what would you say?
Camera port.
What's the distance of the camera port from the anatomy?
10 to 20.
Yeah, so anywhere from 10 to 20 centimeters from the fundus of the uterus, right? So you want to do your bimanual exam and place your camera port. So just going through basic port placement anatomy, and then your instrument ports are how far away from that?
8 to 10.
8 to 10, and then your instrument, your assistant ports are 5. Good. So you also just want to reinforce that you have a certain amount of distance from the camera port to the instrument port, and it's best to have it as a kind of triangulated, and you don't want anything in the no port zone in that area. Have you guys heard the baseball analogy, the baseball diamond analogy? So it's almost like, you can imagine a baseball diamond. You have your pitcher, your person that's up at bat. I'm not like a sports person, but your person who's up at bat would be the fun is almost like
The batter?
right?
The batter?
Home
The
plate.
batter, there you go. The batter is your,
That guy.
let's say that's your uterus. And then the pitcher would be your camera arm, right? And then your first baseman and your third baseman, that's almost like your instrument arm too. And you don't have anything else in the infield. And that's sort of the same philosophy. You don't want anything in the infield. Okay? So,
Your assistant board.
the shortstop is your assistant for you. There you go. Okay, good.
The
So,
catcher.
so anyways, you just kind of want to go through what porn placement is, and then I would actually have someone come up and do it if I was doing this as an in-service. So I would have, let's say they're, they made their incision, they're placing their camera port, and then I would have, if you want to get the camera, and we'll put the camera in the scope. And when we do that, we're just gonna place, let's say, 2 arms. So we're gonna use, let's use the bladeless, soft sterile things. So do you want to go ahead and come up? So what I want you to do is so you're gonna go ahead and place the scope in. You have a good view of in there. So I want you to go ahead and place your port using your obturator. And oftentimes, that's just like you're holding it, that's correct, that's how you're gonna be doing it. And so I want you first, as you're placing the camera, perfect, so you can actually see, oftentimes what they'll do is they'll palpate it. You see, you can kind of palpate the skin, and you can kind of see where you're at. So that's where you know, and it's perfect because his scope is aiming right there. So go ahead and insert, and perfect. Okay, so obviously we had our hole already. So go ahead and push it on through, and you might want to push the camera back a little bit so you can see, there you go. So you can see the remote center, so you want the remote center to be right at that level of the peritoneum, and of course our pelvic model is not a real person, so it's going to be a little bit more challenging with that. So perfect, so it's in the right place, so go ahead and take off the obturator. Alright, and now let's do the other side. Actually, he can hold if you want to just pretend, let's have you hold the camera, and then you're both scrubbed in, let's say it's your first assistant surgeon. Actually, there's a little bit of a glare, it's hard to see.
So that is inside the remote center?
No, that's just the first one. Oh,
Yeah,
no.
there's the first one.
There's a player.
There it is.
Nice.
There you go. So you can just, pull out your obturator, and so this is what we would do for the insert, is just reinforce visualization of the remote center. All right, so now let's say, and then if we wanted to put our third port in, you would do that as well.
Are we gonna have to use the third instrument arm for this?
No, we did for this one. We don't sit down.
Yeah, it's probably good to do it. Let's do it. I mean, you want your customers using the third arm every time. Oh.
They keep doing this to us.
Because it's not
Because
plugged
it's
in.
not plugged in properly, it's fine.
Oh.
It's just because we're on a switch.
I'm glad that happened. This is how we live.
Tell us how you would handle it. No?
Video now.
Not so much? YouTube's going to love this.
All right, so let's see. So we have port placement down now, all right? So now we're on the third section. You guys with me?
Already over time.
9 minutes, 15
I gave you
seconds.
a lot more description. Hopefully it'll go, a little bit more faster. How long was it?
You're at 9:20.
9:20.
Yeah, but you started.
I started late.
All right, so preparing the patient cart. So you can go ahead and take the camera out.
Oh, sorry. Not that fast.
All right, so you want to go through how to properly position the patient cart. And you could do this either beforehand or afterwards. But so what are some of the things you would point out here?
Center column aligned.
Targeted.
Yeah,
The
so
target.
you want the center column to be in line with the camera arm and with the camera port, right? The target anatomy, perfect. Anything else about the camera arm?
Sweet spot.
The sweet spot,
You also want it on one side so that it's balanced.
So what on one side?
You want the setup
Opposite of
joint
the
on
third arm.
Yeah, the
The
second
second joint.
You guys familiar with what the numbers of the joints
Yes.
are?
I know,
So you go,
obviously.
if you go from the center column to this first joint out here, that's 1, 2, 3. Okay,